In this chapter, we're going to talk about the skeletal system, and then we will also finish up talking about the joints at the end of this section. Our skeletal system has numerous functions. One of them is to support the body. It's also going to provide protection. The more critical the structure, generally, the more heavily encased in bone it is. So, for example, your spinal cord and brain are very heavily cased in bone. Even the heart and lungs are protected by the rib cage. The skeletal system allows for movement. The muscles are going to have something firm to pull on with the skeletal system. It's also going to be an important part of mineral homeostasis, as your bones store a significant amount of calcium in them. It's the site of red blood cell production, and then we also have some triglyceride storage inside of our bones. We can categorize our bones based on shape. The long bones are longer than they are wide. This would include things like the femur, humerus, fibula, tibia, radius, ulna, basically the long bones of the arms and legs. Short bones are more cube-shaped. This isn't going to mean they're exactly square, just approximately equal height and width. We have these in the wrist and the ankle, or the carpals and the tarsals. Our flat bones have a thin surface for muscle attachment. It doesn't mean they would necessarily lay flat like a piece of paper, but they're going to have a relatively flat surface for these muscles to attach to. This would include the cranial bones, the sternum, and the ribs. And then we have the irregular bones that have more complex shapes and don't fit into the categories above. This would include the facial bones and the vertebrae. In looking at the structure of a bone, we have three regions of the bone. The diaphysis is the shaft of the bone. The epiphysis is going to be the ends of the bone. And then the metaphysis is going to be the space where the epiphysis joins to the diaphysis. Generally, on tests that I give, I will indicate these with brackets rather than a single line on the picture. The articular cartilage is going to be on the ends of the bone where it's going to articulate or rub with another surface. This is going to be made up of hyaline cartilage. That's going to make it nice and slippery to reduce friction. Over the outside of the bone, you're going to have a membrane called the periosteum. Peri means around, osteo is bone. Inside the bone, you've got the medullary cavity, and it's going to be lined with endosteum. In that medullary cavity, you're going to have the yellow marrow, which is the fatty marrow. A couple things that you can see on some of the bone pictures is you will sometimes see little holes in here. When you look at them on a bone, they'll almost look like they've artificially been drilled in. These are nutrient foramens where you're going to have blood vessels go in and out of the bone. So there would be one here that would allow that blood supply to come in. Bone tissue is referred to as osseous tissue. Your matrix that makes this up is 25% water, 25% collagen, and 50% mineral salts. This illustration here is a cross-section of some compact bone. The osteoblasts are the bone-building cells. So remember, a blast is a cell that builds something. These are going to secrete matrix around themselves, and then once they are done doing that, they will become an osteocyte, which is the mature bone cell. At this point, there is no cell division. Their job is to maintain the bone. The osteoclasts are going to be cells that will reabsorb bone. So clast means to break something down. They're located in the endosteum, and they've got lysosomal enzymes. It may seem like a contradictory thing to do to break down bone, but if calcium is needed in the bloodstream, the osteoclasts come in very handy in breaking down bone to add to that calcium supply in the blood. When we look at compact bone, we're going to find this making up the cortex or a shell around a lot of other bones, and then it's also going to make up the shaft of most long bones. We have these repeating systems in here that you'll see called haversian systems or osteons. That's this little circular area here. And if you look at this picture, you'll notice there is circle next to circle next to circle next to circle. And within each circle, their structure is the same. It's going to have a haversian canal or central canal that's going to run longitudinally up and down in the center. It's going to carry blood vessels, nerves, lymph vessels. So we can see them going up and down in the bone here. The Volkmann's canals are going to also be known as transverse canals. They'll have the arteries, veins, nerves, and lymphatic vessels as well. They're going to connect from the medullary cavity out to the periosteum, and then with those Haversian canals. So it creates a grid going up and down to deliver blood within the bone. These rings here we see get bigger as you move out. So we call them the concentric lamellae. They're hard rings of calcified bone around those canals. The lacunae are the little spaces between these lamellae. That's where the osteocytes are going to live. The canaliculi are little channels that are going to radiate out from the lacunae. They'll have extracellular fluid in there, and there will be processes, which is just surfaces of those osteocytes, that are going to reach through those holes so they can connect with each other. This provides a means for cells to be able to share nutrients, so the ones that are closer to the blood supply can pass it out to the ones that are a little bit further away. Spongy bone, on the other hand, is called that because it's got more of a spongy appearance or Swiss cheese type of appearance. The trabeculae are the lattice of thin columns of bone that we can see here in this image. The red marrow is going to be in those spaces along with the osteocytes. So we have two main forms of ossification that will occur. This is the formation of bone. Intramembranous ossification is going to occur in the flat bones. Here the bone is going to form directly within the loose tissue. These osteoblasts are going to secrete this matrix around themselves till they become mature osteocytes. This is going to form those trabeculae, and then the vessels will grow in the spaces between. Endochondral ossification is seen in most of the rest of the skeleton. This starts out with a hyaline cartilage model that's made up of hyaline cartilage. If you've seen an image of an infant skeleton, it will look like they've just got little tiny islands of bone, but they don't have the full size bones that we have as adults. That's because the cartilage model is not going to show up the same on the X-ray. It is cartilage in the shapes of the bones, it just hasn't fully ossified yet. So this cartilage model is actually very useful for them. If you think about what happens when you are really young, you learn how to walk, you're going to go through the birth process, which is going to involve a lot of squeezing. If you watch toddlers when they're learning how to walk, they're able to find stairs just about anywhere. They're great at going up the stairs, but they're terrible at coming down them. This allows them to be able to tolerate a whole lot more tosses and tumbles that go along with childhood. As an adult, if you've experienced falling down the stairs, it is really unpleasant and really uncomfortable, and we're not real anxious to repeat the process, where a toddler 2 minutes later is ready to go right back to those stairs that they fell down just a minute ago. So this cartilage model is going to grow, and eventually there's a pH change in the matrix that's going to trigger calcification. The primary ossification center is going to be the region where the bone is going to replace most of the cartilage. And it's got a nutrient artery. This is going to grow towards the center. So I'm going to scroll down a little bit here so you can see we've got this cartilaginous model and little islands of bone in here. Primary ossification center is going to grow from here towards the center. So we can see them here, primary ossification centers towards the center of the bone. Secondary ossification centers, these are going to proceed out from the center. So they're going to grow out this way. You can see them a little bit bigger on here. So the secondary ossification centers are fed by the epiphyseal artery. The primary ossification centers are fed by nutrient arteries. So in between here, you've got articular cartilage. And eventually that articular cartilage is going to turn to bone. It's sometimes referred to as the epiphyseal plate. Between the ages of about 19 and 25, it will completely ossify, and that's when it will become the epiphyseal line. The epiphyseal line can be visualized on x-rays of a younger person. As a person gets older, that's going to become more blended in with the rest of the bone and more difficult to see. So once this is completely ossified, that bone is no longer going to be lengthening. Growth stops at that point. So we sometimes refer to that as the growth plate being closed. You'll notice that each of these little islands of bone has a blood supply to it. In the case of a fracture, it is important that all the pieces of bone do have a blood supply to them in order for them to be able to heal. If it doesn't have a blood supply to it, it may be a case that it may need surgery to help stabilize it into a place where it can get a blood supply to it. So that's just one of the considerations when they're looking at a bone, saying does it need to be surgically stabilized or is it able to be held in place and heal with a cast? But that blood supply is very important. So bone is going to remodel. It's very dynamic. All the little bumps and grooves that are on the bone are there for a reason. You have thickened areas or bumps where there's a lot of stress on the bone. And these hormone changes are what are going to allow that to happen. So the first hormone we look at is PTH, or parathyroid hormone. It's going to work on a negative feedback loop, stimulating the osteoclast to do bone reabsorption. This negative feedback loop is looking at the blood calcium levels. If the blood calcium is low, it's going to release PTH, and it will promote absorption of calcium in the gut, decrease the loss from the kidneys, and break down bone in order to get more calcium into the bloodstream. On the other end, you have calcitonin made by the thyroid gland. It will inhibit the osteoclast activity and keep the calcium in the bone to lower the blood calcium levels. So these first two here are ones that are going to influence osteoclasts to look at the blood calcium levels. The things that are going to influence bone growth, the other thyroid hormones, they're going to promote normal bone growth as well as their normal lean tissue growth. Insulin from the pancreas will promote normal bone growth. Human growth hormone from the pituitary, it promotes growth of all lean tissues, which includes bone. The insulin-like growth factors, they're going to come from the liver and be stimulated by human growth hormone. They're also going to promote tissue repair and bone growth. The HGH and IGFs are going to play a bigger role when you are younger and you're growing. Once a person stops growing, those levels do decrease pretty significantly. So important minerals that we have in the bone, calcium and phosphorus are going to calcify the matrix. They will come together and form a salt, and what the bone actually is those mineral salts. Magnesium is important to support the osteoblasts. For vitamins, vitamin A is important to support the osteoblasts. You want to have the correct amount of it. Too much of it would actually slow growth and repair. So a lot of your prenatal vitamins will be relatively low in the vitamin A amounts because it can also act as a teratogen. Vitamin C is needed for the collagen in the matrix, and then vitamin D is needed for calcium absorption. So vitamin D is a fat-soluble vitamin. You want to have the correct amount, not too much. Too much is associated with bone loss. Currently, the only way to really know what your vitamin D levels are is through blood tests. And here in the Pacific Northwest, especially in the winter months, we don't get a lot of sunlight. So a lot of people actually need vitamin D supplementation to get through those winter months. Then exercise is important. Weight-bearing exercise in particular is going to create stresses on the bone that it will respond to. If there's more stresses, the bone will become more dense and stronger in those areas. If someone goes up into space, one of the things that will happen is there's not the stress of gravity on the bone, and it will actually weaken the bone. So most exercise does have at least a little bit of weight-bearing component to it. Bicycling and swimming are not great for that. They're actually very poor for weight-bearing. If you're looking to maximize weight-bearing, strength training is going to be the most effective at that. So bone markings, these are ways that we identify the little bumps and grooves on the bone. And so these are what these terms mean. If you have one of these terms, they're not interchangeable. So you can't call something a foramen one day and call it a meatus the next. They actually go with the name, but it's easier to remember them if you know what it means. So foramen is a hole in bone. One example would be in the very back, the foramen magnum, where the brainstem is going to come out. You can't see it in this picture here, but it would be in the very back. A meatus is also a hole in bone. On the side of the head, you would have the external auditory meatus, the opening for the ears. A fossa is a flat surface on bone. On your pelvic bones, you've got the two wings on the side, the iliac fossa are examples of those. Condyles are rounded surfaces on bones. Your occipital condyles sit on the back of the scalp or the skull on the bottom of it. They allow the head to sit on top of the neck and have a rounded surface for it to be able to move a little bit. A head is a rounded projection on bone. So if you think of your femur head or the head of the humerus, those are examples of heads. Facets are flat articulating surfaces. We have these in the vertebrae. What they do is allow the vertebrae to slide on top of each other to give a little bit more motion throughout the spine. Tuberosities are a thickened surface on bone. If you feel on your shin right below your knee, you'll feel a little bump in there. That's a tibial tuberosity. It's actually thickened like that because of where the quadriceps muscle attaches to the bone. A spine is an elevated edge on bone. If you reach around on the top of your shoulder on your back, where you feel that what feels like the top of your shoulder blade, it's an example of a spine. It's not exactly the top of the scapula, but it's going to be the most posterior surface of the scapula that you're able to feel. The spinous process is a posterior projection on the vertebrae. You can feel these going down the center of your spine in your back. The trochanter is a thickened projection on bone. If you feel on the side of your hip, that's where your greater trochanter is. So for some of us, we do tend to build up a little bit more tissue to cushion that area a bit. A crest is a sharp edge on bone. If you feel just below your waistline, the top of your pelvic bones, that's the iliac crest. So your axial skeleton, this is going to involve the head and the torso. Will include the skull, the cranial bones, the facial bones, the hyoid bone, which is a strange little bone that's going to support the tongue, but it's not really attached to much. And then your vertebrae. So your four cranial bones, you've got the parietal bones, the temporal bones. Temporal bones are over the ear, parietal are up a little bit higher. Frontal bones in the front, occipital in the very back. For the facial bones, there is more than two, but the two that we have listed here are the two I would expect you to know in class. The mandible and the maxilla. So the mandible is this lower one, the maxilla is the upper one. Sutures are the joints between the skull bones. The frontal suture is going to separate that bone into two halves. The sagittal suture is going to run down the center of the top of your head. It's going to separate your two parietal bones. The coronal suture is going to separate the frontal and parietal bones. This one you can actually sometimes feel pretty easily with your fingers if you rub on your head just past your forehead. The lambdoid suture is going to separate the parietal and occipital, and then the squamosa will separate the temporal and occipital and the parietal and sphenoid bones. Sinuses are hollow spaces in bone that are going to produce mucus. At first, that mucus may seem like something completely pointless, but if you've ever had the mucus dry up a little too much, you know that the sinuses are pretty uncomfortable that way. These help to lighten the skull and give resonance to the voice. So next time you have some nasal congestion in there, you'll notice that your voice sounds a little bit different. It's a change in the resonance. The fontanelles are the soft spots on an infant's head. The anterior one is the most easy to feel. There's also a posterior, two sphenoid and two mastoid that are very difficult to feel. With the anterior one, just even gently rubbing your fingers over a new baby's head, you will usually feel a soft spot in there. And these will ossify at about 12 to 18 months. This is important to allow some compression when the child is born, but it also is going to allow for more rapid growth in there, as their head grows fairly rapidly during early childhood. The vertebrae are the bones of the spine. In most people, there are 24 of them. About 20% of the population actually will have an extra or be missing one, and a lot of times it's completely asymptomatic. There are 7 cervical. We call them C1 through 7. Those are in the neck region. 12 thoracic, T1 through 12. Those are ones that are going to have ribs attached to them. And then 5 lumbars, L1 through 5. Those are right above the hips. C1 and C2 have a unique shape. C1 is more circular shape. It's also called the atlas. C2, the axis, is got its own unique shape. It has this projection that sticks up on the top, the dens. The dens will actually slip through this hole here, and that's what's going to allow most of the pivoting at your neck. Down at the bottom, you've got the sacrum, which is a triangle-shaped bone, and then the coccyx is below that. So here on this spine, you can see there are some curves here, and these curves are normal. These are anterior and posterior curves. They're not side-to-side curves. The side-to-side curves are the ones that are scoliosis, that are not normal. The anterior and posterior curves are normal and necessary. So a kyphosis is going to be anterior concave. It's the side where the cave is, posterior convex. This is normal to have in your thoracic spine. You actually start out with your entire spine in kyphosis when you are in utero as a way to be able to fit in there. As you go through the process of moving onto your stomach, being able to hold your own head up, push yourself up onto the hands and knees, and eventually standing, that's how we actually develop these curves. So a lordosis is going to be anterior convex, posterior concave. It's normal to have this in the cervical and the lumbar spine. So having these in here will actually give us a little bit more springiness as we walk. They do tend to increase a little bit with age, so it's one of the things that contributes to us getting a little bit shorter as we get older. The sternum is the breastbone, and then with the ribs, we have 12 of them. There's 7 true ribs. A true rib will start with bone in the back and come around and attach to bone in the front. We have 3 false ribs below that. They're going to start with bone in the back, and they're going to come around to the front and attach to the cartilage. And then we have 2 floating ribs. These are the 2 lower ones. They start with bone in the back, and if you feel on your side, you'll come to a tender point where the rib does not come all the way around to the front. You can feel where the rib stops on your side. When we look at the appendicular skeleton, for the upper limb, these bones are going to start more proximal and will move more distal out the limb as you go down. The scapula is the one we commonly call the shoulder blade in the back. The clavicle, the one we commonly call the collarbone in the front. The humerus in the upper arm. The radius and ulna are in the forearm. The radius is on the side where the thumb is. It's the side that rotates. Carpals in the wrist, metacarpals in the hand, and then the phalanges of the fingers. For the lower limb, we have the os coxae, which is the pelvis, and it has 3 bones that fuse together, the ilium, ischium, and pubis. The femur is the long bone in the upper leg. The patella is your kneecap. It's kind of unique in that it's a sesamoid bone. It's not actually attached to other bone. It's embedded in the quadriceps tendon. When your knee and leg are relaxed, you can actually move your kneecap around quite a bit because of it not being attached. The tibia is the thick bone in the lower leg. The fibula is the smaller bone in the lower leg. The way I remember it, it's got an L in it. It's the little bone and it's the lateral bone. The tarsals are the ankles, metatarsals are in the feet, and the phalanges are the toes. So both fingers and toes are phalanges. When we look at joints, a joint is where you have 2 bones come together. It doesn't necessarily mean movement. We can categorize them based on their structure or based on their movement. Looking at their structure, a fibrous joint is going to be held together by fibrous connective tissue. It does not have a synovial cavity, which is the space between the joints, and is high in collagen. These are going to be very strong joints. Cartilaginous joints are held together by cartilage. They also do not have a synovial cavity. And then synovial joints have this synovial cavity. It's going to be a space between the bones. It's going to be surrounded by an articular capsule. And this is going to have a lot of movement in there, so they're generally stabilized with ligaments. If we categorize the joints by movement, synarthrosis is immovable. Amphiarthrosis is slightly movable, and diarthrosis is freely movable. So some examples of fibrous joints, they tend to have little to no movement. The sutures in your skull, they're fibrous joints. This is an example of how the suture kind of locks together with this little kind of lock and key shape in here. It's considered a synarthrosis. So if you were to grab your skull with both hands on two sides and try and move those joints in there, you're not going to feel any movement. Syndesmosis, this is at your tibiofibular joint. It's an amphiarthrosis. So the lateral malleolus, that big bump you see on the side of your ankle, you can actually feel a little bit of play in that joint. When you push on that, it shouldn't feel like it's wobbling around, but it should feel a little bit more spongy than when you press into your skull. Gomphosis, this is a peg and socket. Your teeth are this type of joint, and they're considered immovable. So when we talk about what is movable, immovable in here, keep in mind it is relative. If you've had braces, you know that you can make a gomphosis move. If you had those braces off and didn't wear the retainer, you also know the gomphosis will still move back to where they came from. Our cartilaginous joints, we have two categories here. The synchondrosis, syn means without, chondro is cartilage, so it means without cartilage. This is the epiphyseal plate. While it does start out being made up of hyaline cartilage, it will eventually be without cartilage and be all bone. It's considered an immovable joint. The symphysis, this is broad, flat fibrocartilage. This is going to be what you have in your intervertebral disc and your pubic symphysis. For a long time, they didn't think that this type of cartilage was actually able to feel pain, so it seems a little strange. Apparently, none of them fell forward on the bar of a bicycle as a kid. Most people remember doing that, and that it's pretty uncomfortable when that happens because that cartilage can indeed feel pain. So you'll notice here that there are lots of these terms, synarthrosis, suture, syndesmosis, synchondrosis, symphysis, that start with S. Just kind of a heads up, they sound a whole lot more alike on a test. What I would recommend doing is taking those terms, all of those S terms, kind of writing them down on a little card that you carry with you for a few days to just really drill the difference of those into your head. So now with the synovial joint, looking at their structure, we have this picture here. So you're going to have your synovial cavity, which is this space between the bones. Inside that synovial cavity, you're going to have this synovial fluid. Around the outside, you have the articular capsule. On the ends of the bone, you've got the articular cartilage that's made of hyaline cartilage. So this capsule that's around the outside, the outer portion of it is fibrous. We call it the fibrous capsule. So on the outer surface, that fibrous part is going to be tougher, more durable. The inside surface of it is synovial membrane. So the whole thing is the capsule, but it's got a different type of surface on both sides. The outside you want to be tougher, more protective. Inside, synovial membrane, slippery to reduce friction. Then with these joints, depending on where they are, they can have ligaments. Some of them may be inside the joint cavity, some may be on the outside of the joint cavity. They're going to help to support the joint and provide stability. So these joints move around a lot. So one of the things you can have is articular fat pads. So here's an example. You've got a subpatellar fat pad. It's kind of like having a tongue in a shoe. It's going to help hold the laces off of your foot so that they don't rub. That's what it's going to do, is help prevent friction in the joint by holding some of the tissue out of the way. So synovial fluid, we've already talked about that on the inside. Bursas are little fluid-filled sacs that are also going to act like the tongue of the shoe. They're going to help hold things out of the way to reduce friction. So bursitis is inflammation of a bursa. It's usually going to come from excessive movement of it in a way that it's getting pinched or rubbed too much. And generally, what you have to do is look at the movement and go, what am I doing wrong in the movement here that aggravates it? And stop doing that movement if you want it to get better. Some people will try to manage them with anti-inflammatories. Generally, it's going to be a little helpful, not a huge help. In some of the joints, we'll have an articular disc. So here is a little piece of one here. So in this example, the knee, we call it the meniscus. You do also have an articular disc up in the upper body. You have it between the top of the sternum and the clavicle. So what it's going to do is help smooth movement. The meniscus, if it is damaged, has a very poor blood supply to it. They do not heal on their own. Fortunately, these are a very common injury that the orthopedists are really good at fixing them. They're generally done as an outpatient procedure. They usually try and have you up and moving right away with them. So they are very good with the surgical repair, but they're just not going to heal on their own. So our types of synovial joints. The planar joints are going to move side to side and back and forth. An example of this would be your wrist. You can move it side to side and back and forth. Hinge joints are going to have angular motion. Angular motion is like opening and closing something, similar to opening and closing a door. You would have this at your elbow and knee. Pivoting joints allow for twisting. You have this at C1 and C2 when you turn your head side to side, or the radius and ulna when you turn your wrist side to side. Condyloid joints, these are going to move up and down or side to side. This is what you have at the metacarpal phalangeal joints, the MCP. That's where the fingers join the hands. So if you look at how your fingers move on the ends of the hands, your fingers can go up and down, and you can also spread your fingers side to side. Saddle joints are a modified form of this. They allow side to side and up and down. Your thumb is able to do this, but you can also combine those motions for something we call opposition. You can pinch something between your hands and your fingers. If you look at the foot of your cat or dog, they do not have an opposable thumb. They're not able to pinch things. Ball and socket joints, these are going to do rotation and circumduction. This is at your hip or your shoulder. So if you do not have an injured shoulder, you should be able to do a full big circle all the way around with your arm. The leg can do a similar motion. We usually just have other tissue and things a little bit tighter there that restrict the motion a little bit more. So when we describe movements, gliding is back and forth and side to side. This is done at the planar joints. Flexion and extension. Flexion is going to decrease the angle at a hinge joint. So if you bend your elbow or you bend your knee, that's flexion. Extension increases the angle, so that would be when you extend your leg or your arm. Abduction is going to move away from the midline. That would be moving your arm out to the side. Adduction closes towards the midline. That would be taking your arms from out at the side and bringing them down alongside your body. Circumduction, it's a combination of flexion, extension, and rotation. So this is at your ball and socket joints, the shoulder and the hip. So when you bring your arm in that full circle around, you'll notice you do have to rotate your hand in there to get all the way around. You can't leave your hand facing forward and go through the full motion of circumduction. Rotation is twisting within the joint cavity. We have this at the ball and socket joints. You can twist your whole entire arm with your arm straight to have your palms face forward or your palms face back when your arm is just hanging at your side. Elevation and depression, the jaw and scapula If you're talking, you move the jaw up and down. You can shrug your shoulders for elevation and depression. Protraction and retraction, this is moving things forward and back. You can push your shoulders forward for protraction. You can pull them back for retraction. You can push your jaw forward for protraction, pull it back for retraction. Inversion and eversion are going to occur at the foot. These are only at the foot. So inversion turns the soles inward towards the midline. Eversion is going to turn the soles out to the side. It's much easier to do inversion than it is eversion. So most of the time when somebody has a sprained ankle, it's an inversion sprain. The sole of the foot's going to turn in and the leg rolls out to the side. Dorsi and plantar flexion is also at the foot and ankle joint. Plantar flexion is going to point the toes away from the head. Dorsiflexion pulls them up towards the head. Pronation and supination in anatomy and physiology is at the wrist and the hands. Supination is going to be having your palms up. Sometimes you'll hear it being referred to as carrying soup. Pronation is the palms down, so I think of it as P for palms down. So things that can go wrong in here, repetitive strain injuries, they're overuse injuries. They're going to create inflammation that can lead to scar tissue. The problem with the scar tissue is it's weaker, it's more pain sensitive, and it's more likely to injure in the future. So anytime you have swelling, you have the acronym SHARP, swelling, heat, altered movement, redness, and pain. This is largely from extra fluid coming to the area to try and put a patch on the damage you're doing. Pain, letting you know you've got a problem. With repetitive strain injuries, generally, if you want them to go away, you have to change what you're doing. Most of the time, they're going to involve overuse of a joint that was not meant to be used all the time. Very common in the wrist and hands. The computer is a big offender. The mouse does it a lot on people. Sometimes people that have to pull a trigger over and over all day long will have them. To really eliminate it, you generally have to change your workstation or change what you do for a job. So tendinitis, this is inflammation of the tendons. Tennis elbow is an example. These can be from overuse, or they can be chronic, or they can be acute. They will result in scar tissue formation. The acute ones generally have a better healing rate in there because it's inflammation one time, you let it heal, and you don't continue aggravating it. From overuse, they tend to be chronic, and so you will produce more and more scar tissue because of the chronic aggravation. So these things can, once you stop doing the aggravation, the scar tissue can be rehabbed. You can make a pretty big difference in about the first year. It's usually a combination of range of motion, some transfriction massage, some balance work and coordination work in there to help improve the quality of the tissue. It does take time and sticking with it, and that's the hard part with a patient is getting them to put in the time and sticking with it. You have about a year that you can really make a big difference in the quality of the tissue. So sprains and strains. A sprain is going to involve ligaments. Strains will involve tendons or muscles. They're generally going to occur together because you're going to have both of these things wrapped around joints. The severity or grade depends on the level of tissue damage and the amount of fibers torn. These will result in scar tissue. And again, with that scar tissue, it is definitely worthwhile to put in the time to rehab it so that it reduces the likelihood of getting injured again in the future. So that is the section on the bones and the joints.